Dr. Cooper, Andrea, you both know how popular our mailbag episodes are, right?
Yes.
Yep.
They're so popular. We have just been inundated with emails from those of you all over the world. And I'm guessing some of you are saying, I wrote 3 months ago. Where is my answer? How come Dr. Cooper hasn't read my email? Well, we've got a solution. I think you're going to love it. Dr. Cooper, tell us what the solution is.
I will. I'm so happy to have found a solution because I feel so badly for all the people that keep writing these wonderful questions and we just can't get to them all. So what we're going to be doing is a monthly live Zoom Q&A on Patreon. So it's going to be available to subscribers of our Patreon channel.
Oh, wow.
Yeah.
Andrea, you do that on Patreon for some other shows.
I do it for a bunch
Tell
of people.
us more about what
Yeah.
it's like.
You sign up for this one. You sign up, and Dr. Cooper will answer a bunch of questions live, and you're going to get a lot of answers and great comments, of course, from Mark, from you and me. And I think it's going to be a lot of fun, and you're going to get a lot of really extra content that I promise it'll be worth it.
And if you've never done Patreon before, it's basically a platform for creators where you can incrementally support shows that you love. So if you go to patreon.com/fatsciencepodcast, you can check out, we've got a couple of different levels. One of the levels starts with a newsletter and the monthly Zoom call. The second level, which is a little bit more per month, actually involves a monthly Zoom call with providers. But anyone can subscribe to that one as well because it's going to be really good information.
Much more in depth.
Much more in depth. And just go to the Patreon platform, sign up to support the show that you love, and benefit from all of the perks. I think you're going to like it.
It is interesting how many questions we're getting about the hypoglycemia. And as I say, I'm not surprised because it's the one thing that has been so neglected and it's really just always seen as an afterthought when it could be the primary driver of the metabolic dysfunction in the first place. So my mind is always on trying to get that to resolve. One thing we didn't mention is that even though it's genetic or, familial, it can go into remission. So the problem
That's a good thing.
Yeah, by controlling it long enough and stabilizing it, we do see it improve over time to the point where we need less and less of that supportive medication and to the point where we don't need it anymore.
Welcome to Fat Science. I'm Mark Wright, along with Andrea Taylor and Dr. Emily Cooper. So great to see you two.
Hi there.
All right, it's another episode of the Mailbag, and we get so much positive feedback from people all over the world saying we love the Mailbag because it's such a wide range of topics, and you can find a little something for everyone in terms of relevance. So let's jump right in. Our first question, Dr. Cooper, is from Dorothy in Texas. She says, I was very interested in the episode where you talked about the selfish brain because my ratio of fasting glucose to insulin is over 15. My glucose is at the high end of the normal range. My insulin is relatively low. However, you talked about the causes being working out without sufficient fueling, withholding carbs, intermittent fasting. I don't do any of those things, so I was wondering, are there other reasons for having glucose more elevated in relation to insulin? And I guess more importantly, is there anything to be done about it? I'm on Zepbound. I noticed my cravings have nearly disappeared, especially the ones for sugar. No more binging. So how does this correlate with having a selfish brain? Thanks so much. From Dorothy.
Thank you, Dorothy. Thank you for this message. And thanks to everybody who's been writing into us. It's amazing how much correspondence we get, and we're trying to get through these questions. So I love this one about the selfish brain because the selfish brain is so fascinating, but it's based on the fact that the brain will preserve its own fuel supply at the expense of the rest of the body. And so in order to do that, it often will suppress the insulin output from the pancreas because the brain can take up circulating glucose without requiring insulin, while most of the rest of the body requires insulin in order to access that glucose fuel. So that's why it's called the selfish brain. But other medical terms for it are cerebral insulin suppression. That's the same thing. Usually what happens is it affects our fasting state. Not as much once you start eating, because once you start eating, your brain starts realizing, okay, I don't have to be concerned now about the fuel supply because now there's fuel coming in, so I will stop suppressing the insulin. But in the fasting state, there's almost like a intolerance to fasting. And so it's the brain saying, ooh, the body's too hungry, the body's too hungry. So it suppresses the insulin, and that allows the glucose level in the bloodstream to build up more, which makes the brain feel more secure. Unfortunately, it can lead to prediabetes, and in severe cases, it can lead to diabetes. So the most common cause of it would be those things that you listed, Dorothy, like the intermittent fasting, or just cutting out carbs, not eating regularly, not fueling your exercise. But it could also be caused by a problem that can run in families that has to do with blood sugar regulation after eating. And so some people, after they eat, they end up with a low blood sugar reaction. And that also puts the brain in this fear state. And so that's another cause of the cerebral insulin suppression. So the only way to diagnose that is to do what's called a mixed meal tolerance test, where you bring a meal with all the food groups, protein, carbs, and fats. And the carbs should include starches. And then you test before you eat the glucose and insulin. Then at 30 minutes, 60, and 90 is what we do. And the reason is that if you have this issue, you'll see at the 30-minute mark a spike in the insulin often that is abnormal, like where it abnormally is an exaggerated reaction once you start eating. That causes a low blood sugar reaction. So that's something to look for next to see if that's there. There are other causes too, because it's detecting that there's some type of a weakness in that metabolic pathway. And so there is something going on there that's a weaker type of thing that makes your brain feel less secure when you're fasting. The Zepbound does improve it a little bit, but I think it's important to get more to the root of what's going on.
Wow, that's really interesting. She actually did say cerebral insulin suppression. I just skipped that because it was too complicated for my brain. But refresh
It's
us,
hard
Dr.
to
Cooper.
say.
It is. She's on Zepbound. Refresh us again what Zepbound is.
Well, Zepbound is primarily GIP. So GIP and GLP-1 are incretins that our body produces, which are hormones that send signals to our brain that we're fed or that we have enough food supply. And so medications have been made to mimic these hormones. And so they also can trigger the receptors for these hormones throughout the body. So Zepbound is a combination of GLP-1 and GIP, so it's considered a dual agonist, and it's the very first one that is hitting two of the hormones at the same time. It's much more active on the GIP receptors. So it's, from my understanding, it's 5-to-1 ratio. So it's 5 times as effective at stimulating the GIP receptor as it is the GLP-1 receptors throughout the body. But so it's really just trying to provide an external source of security to the brain that says, we have enough food supply, so don't worry. So that's why it might help a little bit with the selfish brain. But in people who aren't fueling well, it really doesn't help in the selfish brain, because otherwise, if it's impairing your appetite and then that causes you to really undereat more or cut out more starches and things like that, the selfish brain kind of overpowers the situation, and the Zepbound doesn't have the power to help reverse that.
Okay, great. Dorothy, thank you for a great question.
I have the next one from Terry from Maryland. And she says, thank you for your wonderful podcast. That's so nice. I've learned so much from listening. I'm hoping that you could address the topic of exercising while taking a GLP-1. I exercise regularly and always make sure I'm fueled beforehand, something I've corrected thanks to your advice. But I've noticed that my stamina has dropped since taking GLP-1. What causes this? And do strategies like increasing carbohydrates or adding more electrolytes help counteract it? That's from Terry.
Hi, Terry. That's a great question.
Yeah.
I hear that too. Ever since we started with liraglutide, which is Victoza and Saxenda, there's a subset of people that feel tired and almost like they have the flu or something when they
I
take
hear
these.
about that on the people say it for like the first 2 days.
Yes. Yeah. It can be a short term initial reaction, but there are some people that just feel that way. It's a very small percent. So it doesn't sound like that's what's going on, Terry,
Yeah.
because that's more dramatic. So I do think that including more carbohydrates is a really good idea because carbohydrates are a primary fuel, that gives us energy. Protein's great and fats are great, but they're more of stabilizers and they also help with like structural things in our immune system. They're not as much of a fuel as the carbohydrates are for our body, especially if you're active and exercising. So I would definitely at least start with that, start to ramp up the carbohydrate content. And you could do a mixture of complex carbs and also more simple carbs, because the other thing about the GLP-1 hormones is that they do, because they slow your stomach emptying, if you eat a lot of fiber, and even if you eat like super high protein, your gut motility will slow down dramatically. So to kind of ease that, and then you don't get access to the fuel as easily. So to ease that up, having some simple carbs in there is good, and that doesn't have to be junk food. I mean, we're talking about just things that are lower fiber carbohydrate options. So I would, try that first for sure. And maybe talk to a dietitian. I'm a big fan of dietitians. But talk to a dietitian and say you really want to up your carbohydrate amount to match more your lifestyle, which is an active lifestyle, and to try to see if that's going to improve the situation. And then also just focus on your sleep and make sure you are getting adequate sleep and high quality sleep. That's another area that I think is worth looking at.
Great. Terry, good question. Next is Erica from Vermont. Dr. Cooper, she says, many of us on GLP 1s are getting letters saying our insurance carriers are dropping coverage. I'd like to hear what you suggest based on our circumstances. For example, if we have 100 pounds left to go versus 20 versus we're in a maintenance mode. If we want to stay on a GLP 1 and self pay, should we get it from these online telehealth places or from the maker directly? And if we can't afford those options, are there other prescriptions we should consider? My particular circumstance, I've been on Zepbound since October of 24. She says, I'm a slow loser, about a half a pound a week on average, but feel great. All my numbers have improved, and I'd like to lose about 40 more pounds. I recently added Wellbutrin, and it's helping me lose a little bit faster, closer to 0.75 pounds a week. I'm on 15 milligrams of Zepbound, and my insurance ends January 1st. My doc says I should expect to be on Zepbound or whatever comes next for life. I felt great about that and would like to do that, but don't know if I can swing it financially without insurance. So she's kind of in a boat that a lot of people are in right now, right, Dr. Cooper?
She really is.
Yeah.
Well, it's great that, Erica, that you have some time because, I mean, we're recording this probably earlier than it's going to air. So, but you mentioned January. And so if you have time, if it's going to be a few months, you can kind of plan ahead a little bit for what you're going to do and shore up the metabolism more while you're waiting, such as like you already did, where you added the Wellbutrin, which is really smart. There are other medications that work with the metabolic system, and we use them based on what the labs are saying, so it's kind of individual. But your doctor could definitely explore the use of some other medications. And so if we have patients who have particularly low leptin levels or high neuropeptide Y levels, we might add specific things like in that family of topiramate, which can help too. So there's all these different generic meds that you can use in the cocktail to shore up the stability of the system if you're anticipating that you're going to have to, or that you may be exposed to some downtime with the GLP-1 medication later, because the GLP-1 or GIP like Zepbound, it's one of the main medications in the group. No matter what the cocktail is, if that's in there, it's a primary one. And so losing that could really destabilize things. So the ideal thing would be, as you said, it was kind of interesting how you said, what's the difference if you have 100 pounds left to go, 20, or in maintenance? And that's a great question because it is different. So say you were in maintenance and you're anticipating this might happen. Well, you wouldn't probably be on 15 milligrams still if you're in maintenance. So that's where you can explore other options that might be more affordable, such as the generic liraglutide, which is Victoza. that's generic. And actually, Saxenda, which is the higher dose liraglutide, just became generic, and it's starting to become available. The higher dose liraglutide is still expensive because it hasn't really flooded the market yet, but eventually it will be a lot less expensive. And the liraglutide, that's the lower dose Victoza, is pretty affordable through Mark Cuban Cost Plus Drugs. They have the best price that I found, and so your doctor could always like check that out if you were worried about the cost. But ultimately, the very best thing if you have 100 pounds left is to try to budget for staying on the medication for sure, because that would be a shame to go backwards at that state. You're not ready to taper it. You want to continue to use it. It's possible that as the weight comes down a lot more, you'd be able to taper it. Even with 40 pounds left, you want to continue it, you know? But if you're at that, I think the only exception would really be the maintenance person of being able to step down to a lower strength med. Everyone else, it's good to shore it up with a stronger cocktail. So in case you had to make it last longer, like go to every 10 days instead of every week or every 2 weeks, it's still going to be effective, at least to have some of it in there. It's not ideal. But I think the manufacturer programs are really going to be the best. It's not good to turn to the online, you know, not FDA tested options. They're getting crazy out there, so you can't really tell what's reliable, what's not. There may be some reliable sources out there, but there's so many not reliable sources now that it's flooded the marketplace. So I think you're safer to stick with Lilly Direct for the Zepbound, NovoCare Pharmacy for the Wegovy, maybe the Mark Cuban Pharmacy for the generic liraglutide, and I think and then seeing if your doctor could get something else through the insurance, because now they're getting more and more indications for other conditions like the
Sleep
MASH,
apnea.
sleep apnea for Zepbound, MASH for Wegovy. MASH is the liver fibrosis associated with fatty liver. And so there are more ways that you can kind of push for these. Now they also got Ribelsis, which is the oral pill form of the semaglutide, like the Wegovy. They got that now FDA indicated for reducing cardiovascular risk and major cardiovascular events. So, you know, being creative and trying to get those other indications in there to push the insurance for approvals, it does help in some cases.
Okay, I have the next question. It's from Ellie in Redmond, Washington. What is a normal spike after meals? Or is it abnormal to see a spike at all? My A1C is controlled with Ozempic, but I see spikes after meals, especially with rice. I'm a Japanese female type 2 patient diagnosed in my 20s with a family history of diabetes.
Well, Ellie has type 2 diabetes, and with type 2 diabetes, after eating, it's very typical that the glucose goes up too high. That's part of diabetes. And so, as we're trying to get better control of diabetes, we're trying to get all the glucose levels down. The fasting after eating, the immediate after eating, and especially like the 2 hour after eating level, trying to get that to return as close to baseline as possible. So the diagnosis of diabetes would be if after eating your glucose is 200 or higher, and that's repeated on multiple testing, then that kind of affirms diabetes in addition to the A1C and the fasting glucose. So, but every single person, the glucose will go up after eating, and that's good. It's supposed to go up after eating from your baseline. So, and so I think what to keep in mind is the GLP-1 meds work mostly on the after eating glucose levels, not as much on the fasting. So, so they're used, like things like Ozempic is used to control that. And I see that you're, on the Ozempic. So what you want to look at is it should rise up after you eat, and not knowing your baseline, we don't know how much would be appropriate. But I mean, ideally, if you could keep it, the first one from going above like 160, 170, so half an hour after, a higher amount is still kind of okay, but it's nice if it starts out where it's not too high. And so at the 30-minute mark, maybe you'll see it jump up to 160, 170. And for someone with diabetes, that's actually good. And then it will be coming down over time. And the key is that by 90 minutes or 2 hours, you want it to have returned as close as possible to the baseline before you ate. That's hard with diabetes. That's one of the characteristics of diabetes is that it doesn't do that. So, rice and other foods, it could be that simple carbohydrates might raise the glucose a little bit more, but I don't think the science really proves so much that a particular food is going to be a culprit. For some people, it may be rice. Some people, it might be oats. Some people might react differently to pasta, and they'll still have bigger spikes when they eat brown rice or something. So it's very individual. That's referred to as the glycemic index, and they found that glycemic index of how foods affect our blood sugar is not that reliable because there's so much individual difference. But I would just keep an eye on it and just make sure your meal is balanced with protein and fat, which also helps prevent abnormal spikes in glucose. So, and just see how much does it rise after eating. It would be not unusual at all for it to rise, like depending on your fasting glucose, for it to rise 50 points or so from your fasting, 50 or 60 from the fasting. So at first, and then the key is, does it come down later? And that's what the Ozempic really works on, is the 90 to 120 to 180 minute level, getting that to come down better.
So, Dr. Cooper, Ellie knows her blood sugar level after she eats. She's a type 2 diabetic. Do type 2 diabetics, do they typically measure blood sugar levels, or is that
Yes.
more
Well, no, they
common for
do.
type 1?
No, everybody should. I mean, it's they may not typically do it, but it's always good to, if you are diabetic, it's not, there's a big popular movement now for everyone to measure
With the
their blood sugar
monitors.
levels.
Oh, all
And
those people with the monitors.
yeah, and that's not necessary really, and it does create a lot of confusion in people who don't really have glucose problems. They start thinking they do and altering dietary intake, and that can get them into trouble. But I think if you do have diabetes, it is good to know what your blood sugar does, for sure, and to be aware of that. And so looking at the fasting and after eating levels. Nowadays, we don't have to use the finger stick devices as much because they're the continuous glucose monitors that work with the patch to detect the interstitial levels of glucose. And that can be very helpful because it just transmits that to your smartphone, and it can create all kinds of graphs and tell you and alarm you if it's high. But as you're observing that, you do want to see from the baseline to after eating, the glucose should go up, but by 90 to 180 minutes, it should return back to the baseline. And if it's not doing that, it means that the Ozempic is not 100% getting that under control. But eating complete meals, incorporating a lot of the complex carbs along with the simple ones, just making sure that you're eating on a regular basis, that is important for people with diabetes.
Yeah. It sounds like Ellie's keeping a close tab on things, which is really great.
That is good.
All right, next question. Jean from, is it Wrentham, Massachusetts? Is that how you say that?
It looks like it.
All right. What are the most important biomarkers to indicate normal metabolic health? If I take a GLP-1 or GIP med, will it help my body over time to produce the hormones without medication? Can they correct the source of imbalance? If I eat whole foods and eliminate processed foods and addictive white sugar, can I maintain weight loss without meds? So this is a really great question, Dr. Cooper. How do the medications change metabolism? And does the body kind of pick up the slack because of meds? I guess it's kind of a complicated question.
Well, and this is a great question, Jean. And Mark, it's great the way that you just phrased that. That question, could it be the body picks up the slack? Because I really believe it does to a large extent. I feel like the medications do train the body, or I don't know about train, but calibrate things in a more normal way. And as we always talk about, the metabolism is regulated by a feedback loop. The feedback loop sends messages from the body to the brain, from the brain back to the body. And all of those messages inform the whole organism of what the food supply is, what your weight status is, whether it should be alarmed and conserve energy, or whether it should be a green light and burn fuel. All of that's controlled by that feedback loop. So when you're introducing what we call exogenous, which means outside forms of hormones the body makes, like the GLP-1, GIP, you're strengthening the feedback loop signals to favor the idea that you're not starving and that you can burn fuel. And so that's strengthening that whole feedback loop. So there are hundreds of other bioactive chemicals along that feedback loop that will respond to that. And then they will start sending out a signal saying, oh, maybe we're not starving. So it's like that telephone game. you know, it kind of is. So you're changing the message in the feedback loop to be more favorable, to favor fuel utilization versus energy conservation, and by adding those in. And so if you abruptly remove that strong signal, it won't hold, But if you have a person, because as I say, I've been doing this for 2 decades with these medications. And I have patients we have hundreds of patients with more than 10 years of data. And we have patients who have successfully tapered off the medication. Of course, that is a small percent versus the people who have to take these for their lifetime. And the reason for that is that we call these glitches in the feedback loop. And Andrea has the saying for that.
And as a saying,
Yeah. But the glitches within the feedback loop, they are very disruptive. And most of them are genetically regulated, caused by our genes. And so they're built into that structure. They're like kind of little spots that create these hangups in there and that keep saying, no, don't burn the fuel. And yes, conserve energy. And so it's very difficult. And that's why most people that have metabolic dysfunction are going to need to take a medication to counteract those glitches, probably for the rest of their life. I mean, honestly, that's it. When I started, I thought, well, maybe this is just like a 5-year process till the weight comes down. But then you start realizing, no, it's more complex than that. There are people, though, that are at a normal weight and their blood levels look really good. And you can look at some of the other signals from the feedback loop that we've talked about, leptin, and then you can look at ghrelin and some of the brain chemistry, AGRP, neuropeptide Y, glucose levels. You can look at insulin, all these things, and get a sense, really the feedback loop's working great and the weight's stable. Let's see what happens if we taper it a tiny bit. So then you might taper the medication a little to kind of take away that little bit of the signal. And what I see a lot of times is that the person's own metabolism can compensate for that if it's small increments and over a long period of time. And so we do have a group of patients who have been able to, usually it's like a 2-year process of tapering very slowly and monitoring things. And there are some people that can do that or taper down to very low levels. But I wouldn't have that as your goal. I wouldn't think that's where I want to get to, is just get to a point where my body will maintain this by just eating well, like eating healthy and clean, because that doesn't work. Eating healthy and clean didn't correct it before the medication. So why would it do it
Why would
after?
it do it now?
Exactly.
But,
And I think
but
that's
eating healthy and eating well, that should always be what you do.
absolutely, that should be for everyone, as we always say, that, really nutrition and physical activity and
Good
good
idea.
sleep, they're
Good idea.
all right, really powerful for our general health, but it's just they're not powerful enough for correcting those metabolic
Right.
glitches in the feedback loop.
We all did that before. We all did it before, and it didn't work on its own. Like your hormone stuff wasn't strong enough on its own to make it work. You
Right.
needed help.
One thing is we have to be aware, because it may be the insurance companies are going to try to convince people that what Jean is saying can be possible.
Oh, yeah.
They're going to, because they may not want to continue these long term, these meds.
Well,
And so
that's why they always say with diet and exercise on the medicine. It says that.
it does. But then I think they're going to also promote saying that Well, now that your weight's normal, we're not going to cover these meds anymore. Now you're going to go into a program that helps you like eat the way that it's going to take to maintain this. That is going to be a huge letdown for people because that is not going to work.
No,
And because it's a medical problem, the excess weight is a physical sign of an
a
underlying.
symptom.
Yeah, and I guess we call it a sign because it's something you can see, but it is a physical sign of an underlying medical problem, medical condition that is, it has to do with these glitches in the metabolic feedback loop, largely genetic. So, the idea that just because the medication helped relieve that physical sign because it corrected the glitches, when you take that out, the
The
idea that
glitches come
somehow,
back.
yeah, that somehow it will remain like that without the medication it's not good thinking. So again,
Right,
there are cases, but that's not the common thing.
Yeah, and
right.
I really hope that more insurance companies start taking a more holistic approach to this
Yeah.
because, we've talked about Dr. Cooper when I recently changed insurance companies and they wouldn't cover Ozempic for me because I wasn't diabetic.
Yeah.
And the reason that I wasn't diabetic is
Was
because
because of the
I've been
medicine.
taking the medicine.
But
So,
but it's all medications are affected. So we single out these, but
mhm.
I just the other day tried to help one of my patients change one of her mood medications because it was causing problems metabolically. So there's a one that I wanted to change it to. It was with the GoodRx coupon, it was $600 a month.
Oh my goodness.
Yeah, so we
Oh,
couldn't change it. So, and I'm finding every brand name medication now, no matter what category it's in, is got these huge price tags. So I know we single out the GLP-1s and GIP, but we need to keep in mind this is affecting every group of meds. So people with asthma, people with mood
Eczema.
problems. Yep.
Eczema, it's happening. I have a friend who has that, and it was $1,200 a month, a shot.
Yes. Yeah. And, bone density issues is super expensive. So that's where I think that these online pharmacies that jumped on the GLP-1, they jumped on it because the market is huge, not because the need. And that's what makes me upset about it because you don't see them rushing to produce these asthma drugs or
They
any of the
will.
or the other expensive medications that our patients are trying to get. And but so I think that it is a shame, but hopefully the whole mentality will change and that we'll get some relief with the cost of medications. We'll get more generics available. We should not poo-poo the older meds that might still be approved. Trulicity is one, and
Victoza.
Victoza, yep, and Victoza's generic, as we said. So we shouldn't really ignore those. And then we should also use the other medications in the cocktail that we've talked about that are the generic forms of medications that could be supportive.
Right.
great.
Should I go to the next question?
You bet.
Okay. McKenna from the Oregon coast. Hi there. Can you please advise on the best course of action for managing concurrent hypoglycemia and obesity? I'm a 38-year-old woman and have been dealing with hypoglycemia all my life. I've worked hard to fuel appropriately, which has somewhat reduced symptoms, but I still have high fasting insulin, low leptin, and experience regular blood sugar crashes. I sent you labs in a previous email. I've lost 17 pounds since January. Oh, that's good. But I'm still about 30 pounds overweight. I started Ozempic about 6 weeks ago, hoping it would help my metabolism, and at first it did suppress appetite and reduce blood sugar lows. But even after titrating, that's how you say that, right? Titrating
Yeah.
up to 1 milligram, I'm now ravenous once more. I've only lost 3 pounds in the last 6 weeks, and I'm feeling really hopeless and desperate because the bad hunger has returned, like starving an hour after a balanced breakfast. What would you recommend for someone like me? I'd love to become a patient someday, but currently I can't afford it because I'm undergoing fertility treatment. Thank you, McKenna. She's got a lot of stuff going on, this McKenna. But McKenna, here we go. We're going to try and come up with some answers for you or some help.
Well, McKenna, yes. Now, is everyone starting to notice there's a theme here?
She's got a lot of stuff.
Well, but it's a theme that we're
Yeah.
talking about here. This is what I think people are going to be noticing and reporting is because hypoglycemia has gotten so little attention
Yeah.
over the years. And it's even kind of in the category of like, you're crazy, you know? When patients complain about hypoglycemia, usually the doctor says, well, just eat regularly. Eat regularly, eat every, have your regular meals and snacks, eat every few hours. That'll solve it.
And just to be clear, this is low blood sugar, right?
Low blood sugar reactions, right? And
Hypo means low, hyper means high.
exactly. So, but when I hear this, I can kind of see what is really going on. Let's see how to say it concisely. But hypoglycemia, this is a case where what you have to do is, you guys can guess, everybody in the audience can guess, mixed meal tolerance test. Mixed meal tolerance test. Because at 60 minutes after eating, McKenna is starving and going to be craving sugar. Why? Because hypoglycemia is happening, right? So the blood sugar's dropping in response to eating, which means most likely at the 30-minute mark, the insulin is overshooting and really spiking up. And this is something that runs in families. So the issue with starting people on Ozempic and metformin without doing the mixed meal tolerance test is that you can get into this exact situation that McKenna's describing quickly because the Ozempic and things like metformin, they reverse insulin resistance, if you think about that. So if you have a spike in your insulin, but you're reversing your body's resistance to the insulin, meaning you're enabling your body to take up more glucose when the insulin goes up, can you predict what will happen with your blood sugar? It will drop worse, right? So what you're doing is you're improving the insulin resistance, but you're not improving the spike of that insulin. So it's what I say out of order of treatment. There has to be first figuring out that insulin spike and how to control that before you add those other medications in. Because one thing, little other point, Mark can probably make this more concise because, the spike in the insulin runs in families. It causes hypoglycemia. McKenna said she's had it all her life, hypoglycemia. Usually it starts in childhood where you start seeing it. But the body doesn't like hypoglycemia. So what it does to defend itself, it creates insulin resistance. Insulin resistance is a defense mechanism against the hypoglycemia. So by making the muscle cells resistant to the insulin signal, less glucose can get in the muscles for fuel. That helps your blood sugar not drop as much. And so when you start the whole process as just we need to treat the insulin resistance, and you dismantle the insulin resistance before you correct that glucose spike that was causing the whole thing, the primary issue, you'll start having more hypoglycemia. And so even things like Ozempic, it just misses the mark. Same with Zepbound. So you really just need to, Zepbound actually does a little better on that from our clinical experience, but still not adequate. You've got to really look at the mixed meal tolerance test, and there's ways to control that insulin spike. It's not dietary so much.
Yeah. What are some of the medical ways of treating that insulin spike? Because that's what I had early on. Right?
Yeah, well, and you keep asking me that, Mark, and I've been hesitant to say. But the thing is, I could say, why not talk about the medicines that are used for that? If indeed there is something like that, it's called PPHH, postprandial hyperinsulinemic hypoglycemia. And medications that are called alpha glucosidase inhibitors are really helpful for that. And that's a group of meds that are generic. And so it would be things like acarbose, miglitol. There are also a lot of things in nature that control it that could be in the supplement category that can control it too. Eating foods, balanced and all that helps for sure, but it doesn't resolve it because it's something that happens just when food hits your mouth, basically, in your mouth. Then there are rare forms of it where it's actually certain animal proteins that are triggering it too. That's much less common. And so for those alpha glucosidase inhibitors, they will not correct it if it is coming from a specific animal protein source. And that takes a lot of investigative work. That's again way less common.
I just remembered, Dr. Cooper, and you know that I have diabetes on my dad's side. My grandfather on my dad's side had diabetes. My grandfather on my mom's side, I just remember, suffered from low blood sugar.
Oh, yeah, it runs in
And
families.
yeah, that was very common for him to have those blood sugar crashes. And
I
wow,
think
that's
it's
interesting.
fascinating, really, because they don't really know the genetics of it, but they do know it runs in families. There are some very severe forms that occur at birth and infancy where they're very severe, and they can be so severe that the treatment is actually to remove part of the pancreas,
Ooh.
and to that child would end up on insulin, creating like a diabetes situation that you can control with exogenous insulin.
Huh.
But a lot of times these little children are put on continuous tube feeding for like years, to try to stop it. If it's extremely severe, that's very unusual. And that's usually due to a more specific type of dysfunction. But the alpha glucosidase, I should say glucosidase inhibitors, those are good for what they do is they interrupt that enzyme that's sending the signal to the pancreas that says we are eating. So it just temporarily reconfigures the switch that turns the insulin on so that it doesn't explode, too much with too much force and cause the glucose to drop. But anyway, it ties into this fertility too. Let's not forget that.
Oh, yeah, she talked about that
Yeah,
too.
the reason for needing fertility treatment is probably all because of all of this. It's the metabolic dysfunction. So it makes sense if McKenna is not age challenged, if there's not a rush to become pregnant immediately, because if your age is low enough, may as well try to get to the root of the metabolic problem first before the fertility treatment.
Yeah. We have one more question on hypoglycemia. This one's from.
Oh,
This is a theme.
she
This
said
is.
she's 38. She said she's 38.
Oh, okay. Yeah. Okay.
So that's,
Oh,
and in pregnancy world, that's what they call a geriatric pregnancy, which is so mean.
Yeah. Yeah. So you got to
So
keep
mean.
moving along.
okay.
All right.
This is from Arden in Vancouver, BC. Hello to all three of you from beautiful British Columbia. I agree. BC
Hello.
is one of the most beautiful areas of the whole
So
world.
pretty.
I can't thank you enough for sharing the paradigm shifting information you cover each week. I look forward to listening on my way to work every Monday. So she says, my mother was recently diagnosed with reactive hypoglycemia, and it reached a point where she had to retire and focus on getting well. I've also recently started to have issues, especially as I'm trying to implement the mechanical eating approach in my daily life. Finding information on reactive hypoglycemia is very difficult. It doesn't seem like a lot of physicians have a good grasp on it. I wonder if Dr. Cooper would give some guidance on the basics of management or some resources that we could turn to in order to better understand and manage this condition. Thank you so much. That's from Arden in Vancouver, BC. Wow, so many people with questions about hypoglycemia, Dr. Cooper.
Yeah, and I'm not surprised because this is like a pillar of my treatment process. That is the reason that I do the mixed meal tolerance test on everyone because I think it was about, gosh, I'm trying to think back in time, but it was a long time ago. It was a long time ago. It was close to 20 years ago that I saw people who had severe cases of this. And I didn't really understand what was going on. And I was up like at night trying to think, how in the world is this happening? Why doesn't the body prevent this naturally? How could this happen? And some people have terrible cases. Like it sounds like Arden's mom has a terrible case. She cannot even work. And, that happens. I've had numerous patients who could not function at all because of it, or who lost out on opportunities because we need glucose in our brain and you can't really achieve your best potential if your brain is impaired all the time with this hypoglycemia. And it affects your emotions, it affects your energy levels, it affects your food craving, it just makes you feel crazy, actually, according to what patients tell me. So I happened to have a time where I had a large number of patients at one time with this. And so I started reaching out to all the experts. And I quickly realized that people didn't really understand it or why it was happening. I dug into the history. Someday, we don't have time now, but it is fascinating, the history of when doctors started noticing this and why it's not getting attention. But I don't think we have time now. Sometime we can go into that. But ultimately, as we said, it runs in families, so it's not surprising. If you're prone to this, the other times it can really flare up is if you're going from periods of like restricting your food intake or underfueling significantly to trying to shape that up and then eat more consistently. Because when you're restricting your food, things happen like the selfish brain that we talk about, where your brain starts to worry about the food supply. So it starts trying to suppress insulin. So at first, people with this blood sugar problem start feeling a little better. Plus, they feel better because people with the blood sugar issue, remember, it hits them after they eat. So a lot of people with low blood sugar delay eating, like say they're having a meeting, an important meeting, or have to take a test. They instinctively know I'm not going to eat before that. It's not that they're thinking because my blood sugar will drop. It's their body sort of just says, let's eat after. And a lot of them will eat most of their food before they go to bed because then they don't have to worry about this crashes. And it's a weird kind of dynamic. In fact, it's been associated, the low blood sugar reactions have been associated with increased risk of anorexia nervosa, of eating disorders because of that. But the thing is, anytime you go from periods of not eating enough to where you're trying to eat more regularly, the selfish brain and cerebral insulin suppression alleviates. And that causes the insulin to come back, the high insulin spikes. And at first, they overspike even. So that's why we tell people with blood sugar problems, don't vary your diet much. Be very consistent. Eat regularly. Don't get into where you're not eating enough because then when you go back, it's going to flare up the hypoglycemia. You've got to maintain consistency. But again, everybody knows the answer to this now, right? What's the next step? Mark and Andrea. What's you supposed to do now?
Fasting Labs 30, 60, 90, is that right?
Get your eating test.
What are they called again?
Mixed meal tolerance test,
Oh, yeah.
MMTT. Yep.
Okay.
Meals.
Yep, you're
Eating
right.
test.
You got to
30,
do that.
60, 90.
Yep, and we already covered that that can be just a lifesaver, game changer, the alpha glucosidase inhibitors, if the insulin's caught high.
Yeah.
What it would be is that first insulin, if the insulin is greater than 50% of the glucose, that would be abnormal. So that's an easy little math to do.
And just to give all of you at home an idea of what Dr. Cooper is talking about, when we do our labs every 3 months or so with Dr. Cooper with that mixed meal tolerance test, she actually pulls up a chart that has the graph of the insulin and the glucose levels where you can see how they're reacting together.
Yeah.
And you
Yeah.
can really clearly see, can't you, Dr. Cooper, from
You really
a
can.
visual standpoint, what's going on.
You can. And this sounds like this is what's probably going on now. Sometimes you'll see it's part of a spectrum. So there's a lot more complex stuff to it. So it's possible to not see the insulin and only see the low glucose. That has to do with another hormone, glucagon, that can become dysfunctional with this. So in any case, the mixed meal tolerance test is a great first step to figure it out, and continuing, even though it feels uncomfortable, to eat regularly, consistently, all the food groups, and to carry around fuel, maybe get some glucose tablets at the pharmacy in case you really don't feel well. You can always take a few of those. And those tend to not spike the insulin as much, the glucose tablets. So they're very good to have. Because it can be dangerous, like to drive and everything else when your blood sugar's dropping.
Yeah. Well, these have been such great questions. I think I'd love to just have a kind of a closing thought from each of you. Andrea, after listening to all these questions today and hearing Dr. Cooper answer, what's your takeaway?
I don't know. I love that we get so many questions. I think it's so cool that, and they come from so many places. But this blood sugar issue is really interesting that a lot of people are going through hypo, so many things. But I love that people are writing in. I think people should keep writing in questions. I love it.
Yeah,
I think it's really, I mean, we'll try and answer as many as we can. It's
I
so
like it.
great.
And I guess my takeaway, Dr. Cooper, is that every time we get an email from someone, it's so clear that everyone's metabolism is so
So
different from the
different.
next person.
Yes,
Like no two people are the same.
I
No,
know.
Crazy.
no.
Well, you can tell it also, like when your friends all say stuff to you, and you're like, that they think that their problem is the same as yours, and you're like, No, I don't have that. Yours is different, so I
It's the same.
can't. It's
Yeah.
not parallel, but here's some interesting something that you could look up.
Exactly. Yeah. It's like, parents telling new parents how they
Oh
should
yeah,
do it
Yeah, yeah.
when it may be their
yeah,
child's different. But the thing is, fortunately, there are some common themes, and that's what
yeah,
enables healthcare practitioners to really get some footing on helping people resolve some of these issues. But it is interesting how many questions we're getting about the hypoglycemia. And as I say, I'm not surprised because it's the one thing that has been so neglected, and it's really just always seen as an afterthought when it could be the primary driver of the metabolic dysfunction in the first place. So my mind is always on trying to get that to resolve. One thing we didn't mention is that even though it's genetic or, familial, it can go into remission.
oh,
So the problem
that's
by
a good thing.
yeah, by controlling it long enough and stabilizing it, we do see it improve over time to the point where we need less and less of that supportive medication and to the point where we don't need it anymore in a large percent of people. So not everybody, but
Mm.
but that's also kind of fascinating. I think the whole area is very fascinating. I've always been really intrigued by this hypoglycemia issue.
But getting back to that mixed meal tolerance test, if your doctor is just taking a snapshot of glucose or insulin, you can miss a lot of stuff, right?
You really could miss a lot of stuff. That's why I think it's great that a lot of we're doing a training program soon for healthcare providers, and going to try to keep those training programs up and trying to keep up ways for providers to bring up cases and show examples of these things because I think raising the awareness there is really needed because as I say, it's not getting attention at all in the medical curriculum, the hypoglycemia aspect or this hyperinsulinism. It's still reported as being very rare when it's extremely common. And you find that a lot with a lot of medical things that aren't tested for. They could be really common, but the records are saying that they're rare because
Yeah.
nobody's reporting
Well,
these.
I think a lot of things that deal with metabolism, doctors, I hate to say it, but doctors are not as educated as they should be, because as we've learned, there are not a lot of paragraphs in the medical school
Yeah.
textbooks, and that's why you have the course.
Yes, we have the course, and it takes a long time to get like the science and the consensus into textbooks. And if you don't have a lot of providers on the ground doing the in-depth assessments and things and monitoring over many, many years, the knowledge is not there.
Right.
It's not strong enough or powerful enough because you can't really replicate that in research studies.
Yeah. So they should all take the course.
I hope
There
so.
we go. Well, thank you so much to all of you who wrote in. And for those of you at home, if you have a question, just go to our website, fatsciencepodcast.com, and leave a question for us. Leave a comment. And thanks to those of you who are supporting the podcast. And for another edition of Fat Science.
No diets, no agendas, just science that makes you feel better.